Hello, everyone. Thank you for attending today. Our webinar today is Back Pain Prevention and Management in the Workplace with Friederike Schaafsma. This webinar is part of our Return to Work, Stay at Work series, and we're glad to have you here with us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. And this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships to our organization. As I mentioned, my name is Tanya, and I'll be moderating the session today and handling the Q&A. And our speaker is Dr. Friederike Schaafsma. Dr. Schaafsma is the senior researcher in the Department of Public and Occupational Health at the VU University Medical Center. She worked as an occupational physician at the Garbo Groep GAC and at the Academic Medical Center in Amsterdam. She worked as an occupational physician for Arbe Butler as well in Amsterdam. In 2012, she started her position as the senior researcher at the Department of Public and Occupational Healthcare at the VUMC, and her research topics focus on occupational healthcare and insurance medicine. We're glad to have you here with us today, Friederike. I will hand it over to you.
Thank you, Tanya, and thank you for your introduction. So my name is Friederike Schaafsma, that's how you pronounce it in Dutch, and as of a few weeks I have to tell everybody that I'm 46 years old, and this is how I look like. Tanya also mentioned that I work at the VU University Medical Center, so this is the logo. And all the research that I'm involved in is until the end of this year at the Institute for Health and Care Research, and from 2017 onwards this institute will become the Amsterdam Public Health Institute, and we will align with the other University of Amsterdam. Now I'm showing you a picture of a very nice conference that we organized just this September. With a nice picture of Amsterdam where our universities are both located, and we had a conference on work disability prevention, and also the topic of back pain was discussed there. So I will be talking to you about prevention of back pain in the workplace, and what knowledge is out there regarding work-related risk factors. What do we know about effective interventions to actually prevent back pain in the workplace? And then I'll start talking to you about how to manage back pain in the workplace, and what do we know about risk factors for sickness absence related to this back pain, and what is the knowledge at this moment about effective interventions. And I'll finish off with some recommendations for practice and also future research. So, you all joined in for this webinar, so I guess you all know that what is back pain, but I thought it's still good to start off with discussing, so what do we consider back pain? And we all need to realize that back pain is actually a sort of a symptom that originates from a malfunction or a structure in the back. And even though pain is often not felt in the back, the definition also includes pain radiating from the back to the buttocks or in the legs, but the cause is located in the back. And probably all of you also know that the majority of cases, and many research talks about up to 90% of the back pain, is called non-specific because we do not know what the cause is of the back pain, and it can't be located with the current diagnostic methods. So that's why we talk about non-specific back pain, and this will be also the focus of this webinar. Then we are also, majority of people also mainly talk about low back pain, and that is because most of the time when the pain is actually felt in the back, it's usually in the lower part of the back, and that's why this adjective is there. But there's not really any difference between low back pain and back pain that is felt in a higher part of the back. We do know that research shows that low back pain is reported 4 times more frequently than mid-back pain. So how often does it happen, back pain? Well, there have been quite a lot of studies looking at how often do people report back pain. There was a large study by Hoy and other people in 2014, and they looked at the global burden of disease and focused on back pain as well. And they focused on 291 conditions overall. And they found that low back pain is actually highest in ranks in terms of disability, years lived with disability, and 6 in terms of overall burden. And they measured it in DALYs, disability adjusted life years. And if you have at any point in time, you measure the point prevalence of low back pain all over the world, they calculated that it's about 9.4%. So this is a huge number of people at any given time in the world have back pain. And we also know that over the last 2 decades or so, the disability adjusted life years, so people with pains in the back causing disability, has actually increased. And probably one of the main reasons for this is that the world, that all the people in the world are increasing with age, and that the prevalence and burden of back pain also increases with age. And this is actually a big problem, because now we know that the working population is also increasing with age, and so there are more people working, and they are getting older. So the expected burden of back pain will also increase even further. If you talk about the burden of back pain, many research also looks at the economic costs of low back pain. And we know that the majority of costs are due to productivity losses. And if you are a worker and you have back pain, then you become less productive. The cost will be probably for your employer. But you may also call in sick, go on sick leave due to the back pain. Still, the costs are for the employer, but maybe you as an individual also have some economic costs due to your back pain. If you actually become work disabled due to your back pain, then probably your personal income will decrease, and probably the income tax for the government will also decrease. And if you actually exit the labor market, go on an early retirement, then again your personal income will decrease, and this time the government will have to pay you some money because of your retirement. So again, there's costs for the government. And we also know that, of course, back pain also causes quite a lot of healthcare costs. But if you compare, so where does the majority of the costs go to, we do know that the indirect costs, so the productivity losses, cause the major part of the full, if you look at the complete picture of the costs due to low back pain. If you look at all the research and the ideas around low back pain, there has been some changes in how to look at the courses of low back pain. I was educated as an occupational physician that you have either acute, subacute, or chronic back pain. But now people are talking much more that all back pain is actually a recurrent condition or a chronic condition. And already lots of people in their youth or when they're an adolescent will have an episode of back pain. And so there's no such thing as an initial episode of low back pain in an adult. And there are also some studies who say that maybe we should look at back pain in sort of clusters, and these clusters all represent a different course of the low back pain. So you may have an episode of back pain, and this episode doesn't go away, it becomes persistent, but maybe the complaints are not that terrible, so this is the persistent but mild cluster. It may also be the case that you recover from this episode of back pain, and maybe for a few years you will not suffer another episode, so you recover. But then at some point in your life you may have it again. Then you have the more severe and chronic back pain, which is the troubling one for healthcare professionals, and for the workplace, and you have the fluctuating courses. Of course, this is just the ideas that are arising in the research papers that I've been reading over the last few years, and I think the main point here is that maybe low back pain is something that comes back every now and then, but there are some people who unfortunately don't recover, and these become the chronic cases, and they are the difficult ones. So we are going to discuss the knowledge about work-related risk factors to cause low back pain. And it was calculated from a study published by Driscoll in 2014 that about 1/4 of the population that have back pain is probably caused by work factors. And if you look at the study, they also say that the older you get, the more relation with the workplace could be found. And if you look at the different branches of where people work, then the relative risks in a branch such as the agricultural sector is actually high, or in this case highest, with a 3.7 relative risk compared to another branch that has a relatively low risk. And this shows that apparently in the agricultural sector you can think that there's a lot of physical labor there, so there's a higher risk. And if you understand that in the world, we live in a Western world, and probably we have more sitting jobs behind a computer, the attribution due to work causing our back pain is not so high compared to people living in Africa or in Asia. So what are these work-related risk factors? Well, there are so many studies evaluating and assessing the risk of low back pain and work-related factors. And with all the individual studies, there have also been quite a lot of systematic reviews combining all these studies and looking for evidence. And if you look at the particularly physical factors from the workplace, then factors such as lifting, manual material handling, or maybe patient handling have been assessed or analyzed. Physical work as a whole, for example, the physical work that we have in the agricultural branch, whole body vibration, workers who have to work well, for example, with the big, how do you call it in English, the cars with lots of vibration for the sitting person, the one who's driving. People who have to stand the whole day, working in a static posture, and standing, walking, and prolonged sitting as a whole have also been studied quite a lot, with all kinds of systematic reviews. And I'm showing you now the older reviews, and these reviews mainly said that all these factors do have a relationship with low back pain, the incidence of low back pain. However, about a decade later, because if you notice, then these older reviews were about around 2000, and about a decade later there were some researchers who had published a series of 8 systematic reviews, and they said actually can't find that much evidence about physical factors to causally be related to low back pain. And they actually looked at the same factors as the ones that were studied in all the other systematic reviews. So you can imagine there was quite a lot of discussion going on in the literature, in scientific literature, people saying that they didn't do their analysis in a correct manner, and whereas those other researchers said, no, you haven't done it in a proper manner. And I think that the last few years, most researchers agree that there are actually work-related physical factors, mainly lifting or whole body vibration, that should be considered as a risk factor. But if you look at the prevalence of low back pain and the risk related to lifting and whole body vibration, there there are lots of other reasons why people have back pain or not. And for other factors, for example, walking, standing, or sitting at work, I think even those researchers that published the previous systematic reviews now agree that maybe this relationship isn't very strong with these risk factors. I want to illustrate you a very interesting study I find by Coenen et al., published in 2014. And he was a researcher that did a health impact assessment, and he analyzed the effects of 8 studies, longitudinal studies, and he could have analyzed the effects of exposure response from these studies. And he could actually pool the risk estimates. And he focused on the frequency, so the number of times that you actually have to lift a load per day, and the intensity, so how many kilos do you lift. And he could not pool the duration, so how long would you have to lift this particular load. And if you look at his study and this figure, then you can see that he looked at a few studies, and the individual studies, they have quite a large confidence interval, meaning that there's quite a lot of uncertainty about whether or not there's a dose exposure relationship. But if you combine these studies and you pool all the data together, you do find an increased risk for both the number of kilos and the number of times that you actually have to lift a load. So I think this was a very clear study showing that intensity and frequency of lifting can predict the occurrence of low back pain. If you look at their research study, they actually calculate how much risk increase there was if you lifted loads over 25 kilograms or lifting over 25 times a day. And they calculated the annual incidence of low back pain would increase from to 4.3 times or 3.5 times compared to the incidence of not being exposed to lifting. So this is, I think, a very clear study showing that there is a causal relationship. So then, besides the physical factors for low back pain, how about the psychosocial risk factors at work? Because also in the older systematic reviews, there were quite a lot of reviews that concluded that psychosocial risk factors also have a relationship with incidence of low back pain. However, even in these older reviews, the authors did conclude that the evidence wasn't very strong. And there was also one of the systematic reviews by Hartwigsen, and he concluded that actually there is no relation with psychosocial risk factors and incidence of low back pain. And I think over the years, most people agree that probably psychosocial factors are not the direct cause for incidence of low back pain, but may have some sort of a contribution. And the idea is that maybe how people perceive symptoms or respond to symptoms and feel about their work, it has a contribution to, well, not so much the incidence of low back pain, but maybe how the back pain is perceived. And that's why most people think that psychosocial factors may be an important factor for diminished recovery of low back pain, and can also be the reason why people actually call in sick due to low back pain. And if you talk about psychosocial factors, there have been many factors studied about how people feel about their work and how they feel about their colleagues. And so there's a very long list, and I'm just showing you a few of them. For example, high work strain. So if you have to work long hours, or if you feel that there's a lot of time pressure on your job, and you feel you're not in control of how much work you have to do on a day, or maybe if you feel that most of your colleagues are not very supportive, or you feel that your supervisor is not very supportive, these kind of factors may have may be a reason for people that suffer low back pain for not recovering in the easiest or fastest way possible. So probably what causes back pain? Well, there are some environmental factors, including the occupational factors, particularly the lifting and the whole body vibration. But obviously, back pain is caused by also your genetics and your how your anatomy is structured, and that makes it difficult to actually prevent low back pain. And so that's what makes it also difficult to prevent low back pain happening at the workplace. But if we still want to try, what do we know about effective interventions to do this at the workplace? And well, there's a few things that really have face validity. That, for example, that we set some limits about how much weight can you lift in a healthy manner. For example, NIOSH actually has some recommendations about how much weight should a worker lift on a daily basis, and what should the conditions be about this lifting. And if you want to see if in this company all the workers do this in a safe and a healthy way, you can actually use their lifting equation calculator, and they will, and you have to put in all kinds of numbers about how what the distances are between the load and the worker, and then they will advise you about the recommended weight. As I told you, this the effectiveness have not yet been evaluated. It's more face validity and knowing that over 23 kilos becomes a bit more unhealthy, and there's a higher risk of low back pain. Same goes for whole body vibrations. We simply agreed, and most countries comply. Let's set some limits for exposure to whole body vibrations, knowing that if you expose workers to too many or too high intense vibrating mechanics, then it can be increasing the risk of low back pain. And again, although there have been more studies evaluating the effects, it has been very difficult to also show the effectiveness of measures to further reduce the exposure to a whole body vibration. And I know a study by Timus et al., who is also from the Netherlands, that it was really difficult to, in practice, show an effect of setting more limits for exposure, but particularly to further decrease exposure when it was just above the standard. And the difficulty is also because most of the vehicles that workers use for their work already comply to these exposure limits. So these are the limits, the limits for lifting and the limits for how much exposure on a daily basis should we expose our workers to. But you can also try to change the workplace. For example, change the way a workplace is organized, or maybe focus on how the ergonomics are in the workplace. However, again, all these types of interventions have not yet been proven to prevent low back pain. And probably one of the reasons for this is that the cause of low back pain due to the workplace is very limited. So the fraction that is caused by the workplace, but there's also an issue that not always the compliance to these ergonomic advices is very high, and that's why it's very difficult to prove a change at the workplace to be effective. And over the last few years, or the decades of years, there has been much research going on in the participatory approach, and the participatory ergonomics, to focus mainly on the implementing of all kinds of ergonomic measures, and seeing that as the biggest challenge. So not so much evaluating the effectiveness of an ergonomic measure in itself, because usually in a laboratory this is effective, but in daily practice it is not, but focus on how to properly implement these measures. And there are all kinds of ideas about the participatory ergonomics program, but the basic idea is that it's a sort of a stepwise program in which not the ergonomist or the occupational practitioner decide what needs to be done, but it's the worker, him or herself, together with the supervisor. And this stepwise program, if you follow up on this, will get you organized to do this. And just to illustrate you, for example, step one, creating conditions, focuses on that if you want a company to comply to such a program, you need commitment from all the layers in a company. The management needs to agree with such a program, and they need to be willing to invest time and money to execute the program in a proper manner. And you also need commitment from the supervisor or the employees from a certain part of the company. And then together they have to sit and discuss what problems do they see. And the employees have to tell what they think may be a work-related risk factor, and the supervisors can say, well, this is what I see. And then they need to sort of find a consensus and discuss, okay, we agree that these are the most, that we agree on these risk factors, so what can we decide on how to solve these risk factors, how to get these risk factors out of the way. And again, the employees have the same voice as the supervisor, and the specialist or the ergonomist simply sort of has a role as a process leader. And then the idea is that not so much the most effective measure is implemented, but the measure that these workers feel is the most effective. And the basic idea is that then probably the compliance will be higher, and the duration of that the implementation will also be better. So there have been quite a lot of studies evaluating such programs, also in Canada and the USA, but also here in the Netherlands. And the unfortunate thing is that, again, with the participatory approach, most of the implemented measures, again, although implementation goes better using such a program, but most of the times it are the most simple and the less expensive ones. And Teresa et al. Said that mostly the low-hanging fruits, so the easy, simple measures are most often implemented. And then it's very difficult to show an effect on prevention of low back pain. Recently, our department also did an overview of studies evaluating this approach on an organizational level, and we did see an effect on improving determinants of health behavior or health behavior in itself. And we also saw that the participatory approach is effective in actually reducing the symptoms of low back pain. It also is effective to reduce the duration of sickness absence due to low back pain. But we couldn't find any studies that actually showed any evidence on preventing the incidence of low back pain. So this is so much about how to change the workplace. Then how can we prevent low back pain by using the individual worker? Well, probably physical exercise, advising to do physical exercise and to stimulate all the workers to be as healthy as possible and have strong back and abdominal muscles is probably the most effective to prevent low back pain. If you do this in a more organized manner, for example using back schools or educational programs, then it becomes more difficult. And we think that maybe the reason to show an overall effect, or the lack of overall effect of these type of programs, is that there is quite a large variety in type and intensity, And it's also very difficult to achieve long-lasting change in behavior from these types of programs. We do know that physical exercise together with some sort of education, on the other hand, can be effective as well. There's also the option of screening your worker before they actually start working with you. And there's a very large Cochrane review evaluating the effect of all kinds of pre-employment screening programs. And unfortunately, this review showed contradictory results. And their conclusion was that pre-employment screening is probably only effective for very specific job demands. And you need to think about, for example, firefighters or ambulance staff, people that need to be in a very healthy condition, military people. But for the regular physical jobs, it has no additional effects. Then there is also quite a lot of research, and there's quite a lot of, if you go on the internet on manual material handling, all kinds of advices and devices. And the idea is that maybe if you train people proper lifting techniques or use mechanical aids such as assistive devices, for example, for nurses, this may help to prevent back pain. But again, there was a Cochrane review published in 2011 by Verbeek and others, and they included 9 randomized controlled trials with quite a lot of employees, 20,000, over 20,000, and they also included some cohort studies, and they couldn't find an effect of these lifting techniques or mechanical aids. And they did acknowledge that in lots of studies the workers were actually quite satisfied with the advices or the devices, and said that they knew more and that the advice actually helped them to increase their knowledge. But apparently this knowledge didn't translate into an actual behavioral change, and could be translated into reducing the risk of low back pain. So now we're going to talk a little bit about how to manage the back pain and what clinicians should do if a person comes to their consultation hours when they actually have the back pain. And well, there's quite a lot of knowledge now, and most clinicians will probably use evidence-based guidelines how to handle low back pain. And the basic advice is that you need to obviously differentiate in a very early stage if there's a cause that you can locate or not. And if you're talking about specific low back pain, then you need to check for malignancies, risk of infections or a fracture, etc. And if you say no, there's no specific reason for this back pain, then the idea is that maybe most physicians or physiotherapists will simply say, well, let's wait and see, and don't go lying down in your bed, and try to be active as much as possible. And if necessary, we can advise you to do some exercise therapy or some other forms of therapy. If you are in much pain, you can use some medication for this. And only if it, and you can ask for particular work-related factors. So is there something causing your back pain at work? And usually this will help the majority of cases. But if it doesn't work, then you can sort of advise for physiotherapy, the similar ones that you can do in the beginning, manipulative or exercise therapy. Then there's a chance that it still doesn't work, and most of the evidence-based guidelines that I know of will then say, well, maybe there are some psychosocial aspects, the ones that we talked about earlier, that need to be addressed, also called the yellow flags of low back pain, and maybe now we have to use a more multidisciplinary approach, including, for example, cognitive behavioral therapy, or at least someone addressing these psychosocial aspects. And this approach is called the stepped care approach, and I think quite a lot of evidence-based guidelines now have such an approach incorporated in their guidelines. Despite all these guidelines, and despite the fact that watchful waiting is sort of what you should do in the beginning, there are still quite a lot of people in the Western countries that are referred straight away for diagnostic imaging or specialist treatment. And I think this is not a very good thing. If you, it doesn't really help you that much, and you also risk more medicalization of low back pain and maybe even increase the risk of chronicity or work disability. And there's also something else that has been reported by various researchers, that many patients with low back pain say that their healthcare providers do not really collaborate and give sometimes different advices. Whereas the one healthcare provider say, oh, you need to do this and that, and the other healthcare provider says, no, you should do this and that. And that's what is troubling for patients with low back pain. They need everybody to be on the same side, and all the noses have to be in the same, pointed to the same direction. And in the Netherlands, there's in 2010 there was a guideline by Tulwer and van Tulwer et al. And this guideline, focusing on non-specific low back pain, actually focused on this collaboration and communication between the different healthcare providers. And they also focus on patient-doctor communication. So what do you need to say as a healthcare practitioner to your patient to reassure him or her, and what can you do to activate your patient and stimulate return to work? And also incorporated a stepwise approach, and one of the things that they wanted to achieve was to decrease the use of healthcare, so less consultations with medical specialists and less referrals for imaging. And so I think this is a very good guideline. Unfortunately, this was a guideline that was developed by many healthcare provider organizations, and I think from out of 12 organizations that were included, were 1 or 2 that disagreed with the main outcomes of this guideline. As such, it was never fully officially implemented in the Netherlands. And that's one of the reasons that we are still trying with a research project at this moment to get this guideline implemented in daily practice, because the content is I think very good. So despite this stepwise approach, which I think is a good approach, we all know as healthcare providers that reassurance simply doesn't work for all types of low back pain, or maybe for all types of patients. And some of the patients are at risk for a longer time of back pain, and also for staying off work. And last few years there have been more and more studies that actually sort of try to develop strategies to signal these type of patients in a very early stage, and then maybe already in the beginning you can offer these patients a different type of treatment compared to the ones that have a lower risk of prolonged episodes of back pain. And there are various, and I'm just mentioning here 2. This is a study by Ford, a very recent one, who looked at individualized physiotherapy and showed very good results. And there's also a very well-known study by Hill and others in the JAMA, who use the StartBack screening tool to stratify all patients right from the beginning using physiotherapists with this screening tool. And it's a very simple questionnaire with only 9 questions looking at any type of risks. People are asked to fill in this questionnaire, and based on this tool They are divided in a group of low risk, medium risk or high risk, and the different types of groups will have a different type of approach. And they did a very interesting randomized controlled trial with this stratified approach, and they showed that there were actually health gains for the back pain patients and also for the number of days returning of work. So I think this is a very promising way to handle patients with low back pain as well. Difficulty will be that these type of stratification strategies need to be implemented in daily practice. So now a little bit about risk factors for sickness absence due to low back pain. Well, most of the research say that the strongest predictor is actually a previous episode of sickness absence. So we're not talking about just back pain, but we're talking about also reporting sick due to this. But there are many more, and this is not a full list, not a complete list, but these are the factors related to you as a person, the back pain itself, maybe the workplace, or psychosocial factors. And besides these people that have studied this, there are also quite a lot of other studies looking at all the risk factors. Why do people call in sick due to low back pain, and what can we learn from this? And if you know all this about risk factors for sickness absence due to low back pain, we need to think about interventions directed to the worker. And there are quite a lot of interventions, and there are also quite a lot of risk systematic reviews. There are the physical exercise reviews, the physical exercise focusing on work situation using a graded activity approach. There's the behavioral treatment. There's the multidisciplinary biopsychosocial rehabilitation program, and there's the workplace-based interventions. And overall, we can say from all these Cochrane high-quality systematic reviews, the overall effect is, of most interventions is small, but can still be clinically relevant, particularly regarding the reduction of the number of sick leave days, and obviously particularly for chronic low back pain. The additional effect of the more intense interventions was less clear, sometimes contradictory, and so I cannot say if this is actually effective. So just to show you that the effect was very small, if you look at the black triangle in this figure, then you see that the triangle is not that far from the vertical line in the middle, and this line shows there's no difference in effect. And if you go on the left side, there's a positive effect. And what you want is this black triangle. It's not a triangle, but I don't know the English word. Needs to be as far as possible from this black line, the vertical line. So this is the physical conditioning review showing just a significant effect. If you look at the other review of multidisciplinary biopsychosocial rehabilitation, it's also just effective. It's only just significantly effective. Again, the effect is not very big. There were some studies that particularly focused on the workplace involvement, and also what the effect is of occupational case management, and also involving the worker and the supervisor more. And there's quite a lot of research and the idea is that the more you involve the workplace, the better the effect and the better the cost effectiveness, even for shorter sickness absence. And such a way of doing this is using a return to work coordinator. And such a person or involved in the case management can really play a key role in how to involve these stakeholders and actually sort of facilitate the return to work. And I also think that this such a person has a very important role in if you are talking about the sickness absence and influencing this. And just a recent review also related to workplace interventions, but all the ones that are on top focusing on musculoskeletal disorders, actually used some sort of case management idea where the workplace was involved in some way, and it really showed a big effect, particularly for the physical disorders, the musculoskeletal disorders. And I think that the musculoskeletal disorders in this review was actually the back pain. So in summary, low back pain remains an enormous burden for workers, employers and society. We have no cost-effective interventions yet to prevent low back pain. What you can do to prevent low back pain as much as possible is to set exposure limits. What we know, they are, at least on face validity way, effective for lifting and whole body vibration. Encourage your workers to do as much physical exercise as possible, and although not yet proven effective for prevention, I'm a very big proponent of using a participatory approach in a workplace to try to eliminate any risk factors for low back pain. If you already have people on low back pain and on sick leave, then you can advise to do physical exercise again, maybe with a graded activity approach. I advise to stimulate collaboration as much as possible between healthcare professionals, and a step care approach or subgroup approach is I think a very good way to manage the low back pain. And I think one of the key ingredients is to include the workplace, particularly with a return to work coordinator, to improve the communication. We need to bear in mind that with all these interventions that we can do, that the effect sizes are small. But nevertheless, although there may be small effects on the sick leave in durations or on the level of pain, there can still be a huge effect on costs. And we also need to bear in mind that these small effect sizes are also a relative parameter. And I mean with that reducing sickness absence in effects can be small, but can have still a large impact on reducing the societal costs. And we need to discuss who benefits from such a reduction in sickness absence duration. But I also want to talk to you that the relative parameters also calls that the healthcare for a patient with low back pain is actually already quite good. So every new intervention comparing to the usual care situation now will probably be very difficult to report an additional effect of any new type of intervention. So that's why I also talk about it as a relative parameter. And one last thing here is also that I think that for the more intense strategies related to cost effectiveness, we don't know enough right now. So regarding some recommendations, I think that the stratified approach is very promising, but needs further implementation in daily practice. And I think that it also needs to be further refined, particularly if you talk about sickness absence due to involving workers with sickness absence. And you need to sort of have this, for example, sort of start back tool maybe should also have some questions regarding the work or the availability of a return to work coordinator. And you also want to know if the healthcare provider actually collaborates with other healthcare providers, and particularly the ones that are the stakeholder of the workplace. So that's one of my recommendations. The other one is that I think that of all these effective return to work interventions, we need more effort to implement these interventions in daily practice, and for this we need more research. So why is it so difficult to implement effective interventions in healthcare situations, but also using the workplace? And we also need to involve the insurance system of a nation for this, because I think particularly the typical insurance system of a nation, which is different in most countries, does have a huge influence on what type of intervention is actually implemented in daily practice or not. So what intervention is covered by the insurance system. So that makes it quite difficult to grasp on a global scale. On the other hand, I think one of the facilitators with more trust and respect, and particularly more collaboration and communication, using such a person as a return to work coordinator will probably apply for all the countries where there is lots of low back pain causing sick leave. So I'd like to thank you for your attention with this webinar. Thank you, Tanya. I give it back to you.
All right, wonderful. Thank you very much, Frederike. That was a really good presentation, and what a great overall review of all of the literature. And it's really interesting to see, because a lot of times you can look at research and say, well, it says that there's no effect or small effect, but to have your perspective of that small effect can actually have a bigger effect on something else, like the cost or other things, is really, really helpful, because sometimes it's hard to look at the research and go, well, it says nothing is effective, you know?
Yeah, I agree.
So that's a very good perspective. At the moment, I don't have any questions, so I would encourage everyone, if you do have a question related to the presentation, to go ahead and type it into the question box now. Someone asking thoughts on the sit-to-stand workstation to reduce prolonged static sitting posture for computer users in relation to back pain, I assume.
Yes, well, it's a very interesting question and a good point. One of the problems with that, we're still uncertain whether sitting in itself is a big risk factor for low back pain. We do know that sitting is a risk factor for more health in overall health, and there's quite a lot of research going on that the way that we are now organizing our work with lots of sitting during the daytime is not very healthy. Not so much for your back, but more for your health as a whole. And that's why there's quite a lot of research going on with these stand and sit desks and changing the way that you your posture every now and then during your work day. There's still no clear evidence that this is actually effective on the overall health, and there's also no evidence that this is effective on reducing low back pain. But research is still going on, and people are enthusiastic that maybe, I mean, it's also common sense that we all realize sitting the whole day is not how we were built. So maybe we should try to reduce this in number of hours and maybe change this every now and then. And but to show an effect is just like all the other interventions that I showed you on prevention of low back pain. It's really difficult to show an effect, and one of the reasons is that it's also difficult to get the worker use the sit desk stands the whole day. So most of the times, the first week they really enjoy it and they are very good and do it every half an hour, change their position. Second week they'll sometimes skip a change because it's annoying and they were having they're very concentrated at work, and then usually the compliance wears off over the weeks, and that's why it's very difficult to show an effect of these kinds of ergonomic measures. Back to you, Tanya.
All right. Let's see. I don't actually have any further questions at the moment. Someone was asking about getting a copy of the presentation, and we are going to provide one for download. So that will be available once I post the recording. Oh, okay, we got another one. Let's see. Is it recommended that an employee not return to work if they are still symptomatic, as it may do more harm to the employee's condition Or do you find that accommodation are more helpful than harmful?
Well, I'm an occupational physician, and so I'm not talking as a researcher, but as an occupational physician, I think that a little bit depending on the working conditions, it's always good to stimulate people to go back to work, particularly if they like their work and feel safe at work and there's good co-worker support. I don't think that working in itself aggravates the back pain or causes more back pain. And I think that it's the longer you stay off work it makes it more difficult to eventually go back to your work. So my advice would be, despite the symptoms, if it's feasible, you should do it, and then obviously with some working accommodations. And you can think of either a reduction in working hours, or maybe a reduction in some of the more physical related things that you have to do at your work. And you can discuss with the supervisor if there is some other type of work feasible to do for a few weeks or so, as long as the pain is still there.
All right. Another question, someone asking, are there any concerns or studies linking back pain with walking over uneven ground for work? Say, for example, over rocks, on the side of a hill, or in the forest?
I don't know offhand. I know that there are studies that looked at the I say this in English, the stable underground where you walk on, and that that there is some connection, but I couldn't tell you straight away what studies there are. And as far as I know, that there's no evidence that this is directly correlated to the incidence of low back pain caused by the workplace. But I can imagine, but this is more as a doctor, that if you walk on uneven ground for a large part of your day, but this could also be outside of your work, it can have an effect on your back and the stability of your back, and may cause some back pain. But I can't tell you if there's any research out of my head at this moment.
Okay, and then someone asking, from an international perspective, which professionals are typically working as return to work coordinators? That's
a very good question. I know that this differs per nation, and I've lived in Australia for a few years, and there were return to work coordinators that had all types of backgrounds, from being a physiotherapist to a psychologist. Any type of previous education would suit them, and they would have a sort of training within a company to become a return to work coordinator. And these people would usually work in a company that provided all the return to work coordination. There are also companies, for example here in the Netherlands, that use a return to work coordinator from within their own company. So there's some person that is involved in all the issues when people call in sick for any kind of reason. And but usually these people also have a sort of a health care background, and I think lots of times it's either physiotherapy, or you are a nurse, or a social worker. These type of people usually fulfill this job. And I'm not certain what kind of people in Canada or USA work as a return to work coordinator. And I think it doesn't really matter, but you need to have some sort of background in healthcare, and you need a specialized training in what issues are involved in return to work. And you need to have a trait that you are very good in communicating and getting people to collaborate, because there's quite a lot of tension when, for example, the supervisor gets annoyed that the person is often sick or is too long sick, and there's some suspicion that maybe someone sort of misuses the sickness absence and put some pressure on the return to work coordinator, you make sure that this person gets back to work as soon as possible, and then so you need quite a good good social skills, I think. And same goes for the occupational health professional, sometimes involved in the return to work coordination as a whole as well.
All right. Someone asking, can footwear play a part in symptomology, i.e. steel-toe boots?
Can you repeat?
Can footwear play a role, particularly like steel-toe boots or boots that like construction workers would wear on site?
I don't know. From a research perspective, I don't know, but it's just the same question as walking on uneven territory. That I think that standing on high heels or boots or footwear that's not very comfortable, and it makes you feel if you're not stable while you're standing, then yes, I think it has an effect, and this should be prevented. But this is more me talking as a practitioner than as a scientist, because I don't know offhand about research studying all of this, and obviously you can't do a randomized controlled trial asking 50 persons to wear unstable boots or boots with heels or uncomfortable shoes and compare them with people that can choose comfortable shoes. So it's difficult to provide any evidence, but I think that from it's very reasonable to expect that you need to have a stable underground, particularly if you have to walk quite a lot or stand on your feet the whole time.